Hi, my name is Chrissy, and I'm a University of Michigan nursing student presenting a patient from Heartland Healthcare Center. This patient is a 75-year-old Caucasian female. She is currently widowed and is a retired elementary school teacher. Her usual source of medical care is a private medical doctor paid by Medicare with supplemental Empire Blue Cross Blue Shield. The patient was transferred from the University of Michigan Hospital and admitted to Heartland Healthcare Center on October 12, 2013. Prior to her admittance to the Heartland Healthcare Center, the patient spent 6 months in and out of the university hospital due to multiple exacerbations of her COPD. Her exacerbations included chronic coughing with expectoration, tachypnea, and audible wheezing. The patient's first episode of increased cough and wheezing occurred at age 60. At that time, she was taken to the University of Michigan Hospital and diagnosed with COPD. She was released from the hospital in a week and was instructed to take an albuterol inhaler daily. 6 months ago, 15 years from her last exacerbation, the patient experienced a second exacerbation. This exacerbation included increased cough and severe wheezing. This exacerbation was the start of her 6-month period of frequent visits to the university hospital due to more multiple consecutive exacerbations. While at the University of Michigan Hospital, she was also diagnosed with left-sided heart failure and diabetes mellitus type 2. By October, exacerbations were less frequent and the patient was admitted to Heartland Healthcare Center. Medications at Heartland Healthcare Center include taking a nebulizer 3 times a day to regulate her COPD and numerous medications to regulate her heart failure. At the same time, the patient's diabetes mellitus type 2 is regulated by a low-carbohydrate diet monitored by the nutritionist. While at the Heartland Healthcare Center, the patient currently complains of shortness of breath and inability to walk any distance. The patient explains that she feels as if she has a constant cold and a tight feeling in her chest during inspiration. She compares this tightness to feeling as if there is an elephant sitting on her chest. However, the patient denies any instance of coughing and any sleeping disorders. The patient explains that she has perfect fine motor skills such as eating with a fork and writing with a pen. The patient goes to physical therapy once each day to improve her gross motor skills, which includes walking and elevating from a chair. During the day, the patient sits in a wheelchair and is only active during these physical therapy sessions. At physical therapy, the patient practices walking using a walker. When using a walker, the patient complains of shortness of breath. The dyspnea continues and she is unable to walk 1 or 2 meters. The patient also explains that at physical therapy she is constantly reminded by the therapist to keep breathing and to take frequent exaggerated inspiration and expirations. The patient further complains that she experiences pain in her left shoulder. She relates this pain to a dislocation of her left shoulder as a teenager and rates the pain as 4 out of 10 in intensity. The shoulder pain is treated through the use of non-pharmacologic measures that include a heating pad, which is used before each physical therapy session. Overall, the patient feels that walking is her biggest struggle and is the main cause for her stay at Heartland Healthcare Center. The patient appears motivated to improve her mobility, but does not exercise on her own. The patient has no known allergies. Past medical history includes her recollection of being very healthy throughout childhood despite brief onsets of common childhood illnesses such as measles, mumps, rubella, and varicella. The patient denies any type of surgery and has only been hospitalized at the onset of her COPD. She has a family history of diabetes mellitus type 2, hypertension, skin cancer, and heart disease. The patient recently received the influenza and pneumococcal vaccine within the current year. Functional assessment. The patient denies any drug, alcohol, or caffeine use. The patient denies any use of tobacco, but states that her husband smoked at least 1 package of cigarettes daily in the home. The patient eats 3 meals a day and describes her appetite as being average. In addition, due to the dislocation of her left shoulder, the patient has no history of chronic physical illness, but appears to be overweight. The patient also has no history of neurological illnesses and is alert and oriented to place and time. The patient is able to express clear and appropriate vocabulary based on her age and experience. Psychosocial data. The patient states that she has a good support system within her immediate family and includes that she receives frequent visits from her son and college-age granddaughter. The patient states that she lives alone in a home in a 1-floor house in a safe residential area. The patient identifies her religion as Roman Catholic and has frequently attended church in the past. The patient denies any daily stressors besides the death of her husband that occurred 5 years ago. The patient explains that she rarely seeks medical attention except for when she is feeling very ill. Review of systems. Due to the patient's COPD, it is important to perform a respiratory assessment to identify the patient's symptoms of COPD. Upon inspection, it is evident that the patient has a barrel chest and is breathing irregularly. She has rapid, shallow breathing but does not appear to be in respiratory distress. The patient takes about 1 deep breath for every 20 rapid, shallow breaths and relies heavily on shoulder and neck accessory muscles during deep breathing. Cyanosis was not present and the patient appears to have a symmetrical chest during respiration. Upon palpation, it is evident that the patient has bilateral decreased thoracic expansion and decreased tactile fremitus. During posterior palpation of ribs, thorax, deformities and crepitus were not present. Upon auscultation, breath sounds over the anterior, posterior, and lateral chests were faint. Posterior bilateral wheezing was evident in the basis of the lungs, and crackles were heard in the right middle lobe. Although vocal sounds were barely audible, egophony, bronchophony, and whispered pectoraloquy were normal. Throughout the respiratory assessment, the patient denies any chest pain but experiences shortness of breath and struggle to make deep respirations. Review of system number 2. Due to the fact that the patient has been diagnosed with left-sided heart failure, it is impeccable to perform a cardiovascular assessment. This assessment will help track any positive or negative changes during the contraction relaxation of the patient's heart. Upon inspection of the thorax, there were no heaves or lifts over the 5 areas of the aortic, pulmonic, Erb's point, tricuspid, and mitral of the heart, and there was a normal contour of the thorax. Inspection also presented peripheral pitting edema in the ankles and lower legs and fast, shallow breathing. Palpation presented no lifts or thrills over the 5 key areas. Palpation of the PMI presented a strong, rapid, yet regular heartbeat. Auscultation of the 5 key areas and the PMI presented S1, S2, and S3, but not S4. Auscultation did not present any sign of a heart murmur. Throughout the exam, the patient denies recently and currently experiencing any chest pain or being diagnosed with a heart murmur. Musculoskeletal. According to research found in the articles from the International Journal of Chronic Obstructive Pulmonary Disease, loss of skeletal muscle mass and exercise intolerance is a major problem found in patients with COPD. This research closely associated malnutrition, oxidative stress, and systemic inflammation that occurs from COPD to be a likely cause of muscle atrophy. Therefore, it is important to perform a musculoskeletal assessment in order to find and determine if any skeletal muscle is atrophied. Upon inspection, muscle mass, bone structure, and posture appeared normal. Inspection of the patient's gait presented that she was unable to walk without assistance, and even with assistance still presented a very weak and unsteady gait. The patient denies any neurological problems, and it can be concluded that the patient's abnormal gait is related to muscle weakness from immobility. The patient also presented no sign of scoliosis. Palpation of the temporomandibular joint, neck, elbows, wrist, fingers, hips, knees, ankles, and spine presented a normal range of motion, lack of arrhythmia, lack of unusual warmth, lack of pain, and lack of crepitus. The patient noted pain in her left shoulder due to the prior dislocation. Therefore, palpation of the left shoulder presented a limited range of motion of the left shoulder during flexion, hyperextension, abduction, external and internal rotation, and circumduction. During testing of muscle strength, the deltoids, biceps, triceps, hips, hamstrings, and quadriceps presented a grade 4 muscle strength. The wrists, fingers, and ankles presented a 5 out of 5 muscle strength. Pertinent system number 2. According to research published in the U.S. National Library of Medicine National Institutes of Health, there is a relationship between peripheral arterial disease and COPD. This research included a study completed in the Provisa Hospital in Spain from September 1, 2008 until March 1, 2010 on 246 patients with COPD. Collectively, this research found that there was a high prevalence of peripheral arterial disease in the assessed COPD patients. Additionally, in the Journal of American College of Cardiology, Dr. Stephen P. Marceau and Dr. William R. Hyatt found that the risk of peripheral arterial disease is increased among individuals with diabetes compared to non-diabetic individuals. Therefore, it is important to perform a peripheral vascular assessment in order to look for signs of peripheral vascular disease in this patient who is at an even higher risk of developing diseases associated with the peripheral vascular system. Upon inspection, there is no sign of cyanosis, varicosities, or unequal hair distribution. Inspection presents pitting peripheral edema in the right and lower left leg. Palpation of the carotid, temporal, femoral, brachial, and radial arteries presented 2+ grade. The lower extremity arteries, including the popliteal, posterior tibial, and dorsalis pedis, were difficult to assess due to a peripheral edema. The fingers and toes present a 4-second capillary refill. Research completed at the Queen Elizabeth Hospital in the United Kingdom shows that there may be possible associations with this patient's heart failure and diabetes mellitus type 2 to the patient's COPD. This research shows that COPD may lead to heart failure due to the fact that when COPD causes the lungs to not function properly, the heart receives less oxygenated blood. This causes the heart to have to work harder to push the little oxygen that is available throughout the body. Over time, this constant stress can damage and weaken the heart, leading to heart failure. In addition, this research associates COPD with diabetes mellitus type 2. This research shows that inflammation may spur insulin resistance by activating proteins that block insulin action. COPD is associated with inflammation due to oxidative stress that promotes inflammation in the lungs. This inflammation creates insulin resistance and therefore diabetes mellitus type 2.